κριτική διασύνδεση τόσων πολλών εργαστηρίων και τόσων πολλών προσώπων. Οπότε ξεκινάμε, δηλαδή, μπορούμε να ξεκινήσουμε να μιλάμε στα αγγλικά, υποθέτω, και θα γίνεται η διερμηνία και στις παρουσιάσεις και στη διασύνδεση. Έτσι, κυρία Πιτέλου.
Ναι, να πούμε ότι όποιος θέλει να γυρίσει το κανάλι στα ελληνικά, κάτω στο Zoom θα πρέπει να βλέπει ένα σημάδι που είναι το globe, είναι δηλαδή η σφαίρα, η γη. Αν το πατήσει κανείς, έχει επιλογή για ελληνικά και ισπανικά. Οπότε μπορεί να έχει ισπανική διερμηνία ή ελληνική διερμηνία. Οπότε από εδώ και πέρα, ναι, κύριε Λιονή, πάμε στα αγγλικά. Γιατί εκπέμπουμε και ζωντανά στο YouTube.
Ωραία. And the process already has been started in being recorded. Professor Kousis, we can start?
Yes.
Okay. I feel very privileged being among the coordinators of this very interdisciplinary meeting. And there are many persons that I needed to express my gratitude and my pleasure for giving me this chance. We started from Professor Kousis. We just jointly coordinated this conference with an important subject, health inequality determinants in the pandemic, together with social justice and the rights. I think this is a very challenging subject, and we have been very eminent colleagues and researchers that will try in attempting and responding to this interdisciplinary challenge to many central questions. Already they have been reflected on the first slide. It is a joint actions between many laboratories and sections of universities, but many responsibility is beyond the research center of the University of Crete, and Professor Kousis is the president of this important research capacity in the University of Crete. My name is Christos Lionis, and I had the pleasure in started with this presenting and illustrating some a very important subject that will be discussed during the roundtable, but also from the medical point of view and the healthcare point of view. I'd like in starting the session by giving some important definitions, and I very much appreciate Dr. Petelos if we change the slide and giving the second slide. I think that we needed in discussing a very important notion that the WHO since years, but also EC and many other international organizations and the WHO has already pointed a very important notion that's integrated healthcare. It's pity that integrated healthcare is a missing issue at the moment in Greece, although many efforts and a couple of research-oriented activities already illustrated the need to address integrated healthcare, not only as an important component of the healthcare system, but also as a matter and a subject for interdisciplinary collaboration and research. And in this light, you identify some key words when addressing integrated healthcare, that is a continuum of many activities just having an important impact on the quality of life and quality of care, but also is giving emphasis on coordinated actions across the different levels and sites of care. And also just so importantly, this definition of WHO underline that integrated healthcare services should be driven and offered and provided according to their needs through the life course. Next, please. This is a publication that is giving us opportunity in having an understanding that this subject has been underlined a couple of years before the pandemic, but still the subject is a mission issue from the political and research agenda. Next, please. This is giving an illustration of a very important bridge that should be developed and discussing and making and bringing more close the public health within a primary care. It is a consensus evidence-based consensus paper that has been developed by a research team of University of Crete and the Clinical Social and Family Medicine. Just 2 years before pandemic, is giving emphasis and underline needed to develop the research on chronic communicable and non-communicable diseases. All of this list you can see is a very important together today when discussing the so-called underlying medical condition as an important determinant in predicting severity of COVID-19. Next, please. A part of integration, European Commission, but also WHO and EUFA, and the European Association of Public Health, have stressed the need to turn our attention on a very important subject of vulnerability and vulnerable groups. And this not only definition, but this is a part of an opinion that's an expert panel of a DG Santé in EC has published a few months ago in October 2020. And just a little bit illustrating the term of syndemics. That's so very important for the roundtable today. That's characterized by biological and social interactions between conditional states that syndemics, that is a key issue already illustrated in the Lancet, but also is in common use today when we discuss in pandemic. And the most important that is not only people with underlying medical conditions, but also people with vulnerability, or another term very related is multiple vulnerability. And then the next, which almost I'm finishing this introductory remarks, next slide, and appreciate, is the category of vulnerable people. I'm afraid that we have not a consensus, even when talking in Greece, what it means by saying vulnerability and vulnerable people. But this opinion next to EC, discussing not only those people with underlying medical conditions, that means medical vulnerable, but also that's discussing one important category, which is social marginalized, and also mentally and psychological vulnerable, and giving concrete emphasis on economical vulnerable. That means reconsider all of those important groups in expressing and predicting severity of COVID. That's our attention. That's a term to interdisciplinary collaboration and evidence-based research when we're discussing inequalities, healthcare determinants, social justice, and human rights. That next, please. I suppose that is the end of the presentation. We just giving us some introductory concept could be used in the next presentation. And I'm giving the floor now to Professor Kousis with my extremely important thanks and gratitude for giving the support to this interdisciplinary conference. Professor Kousis.
Thank you very much. I was on mute. I want to welcome everyone on behalf of the board of the University of Crete Research Center for the Humanities, the Social and Education Sciences to this event, which was a product of collaboration with Professor Leonis, Elena Patelos, and the two labs, that the head of the Center for Bioethics Labs and the head and the affiliated member of the Applied Psychology Labs. We envision an interdisciplinary dialogue that is just the first step towards
a fuller dialogue encompassing different disciplines to tackle the very challenging issues ahead of us in this pandemic and in other critical issues of the 21st century, but especially for the event that is related to the UFA Public Health Week. We are very happy to have this opportunity. We are an autonomous interdisciplinary research unit supervised by the University of Crete Senate, aiming to foster and promote research in the social sciences and humanities, but in collaboration with scientists from other disciplinary areas. We have 29 research laboratories, and our mission is to strengthen our international collaborations, especially in the interdisciplinary research and connection within and beyond the University of Crete. I would like to now stop sharing to mention that this event would not have been possible if we were not in close collaboration with Professor Leonis, whose scientific sensitivities on interdisciplinary issues are especially enlightening. And we hope this is only the beginning of further events and collaborations. Now, I would like to acknowledge the support of the interpreters who are contributing with Spanish and Greek translations and their institutions, the Ionian University, ASETRAD, and FIT Europe, as well as our technicians, Yannis Marendakis and Dimitris Akelaridis. The event, as you probably know through the chat, is recorded, live streamed, and posted on YouTube. And for any questions you may have, please use the chat and see the instructions there. Since we're running a little bit behind, I would like to ask Professor Leonis to introduce the first speaker.
You're asking to introduce the first speaker, or you are doing that as already we discussed?
Yes, okay.
Yes.
I will give, apologies for this, I will give the floor to Professor Stavroula Tsinorema. She is the director of the Center for Bioethics, a center that has been established and is one of the most active ones in our university, especially in our schools at the campus of Rethymno. Professor Tsinorema is expert in political philosophy. She's very active as an advisor and expert in many different international organizations. And she's the head of the ethics committees, not only in our university, but in other institutions as well. I give her the floor. I also would like to mention that the analytic brief biographical notes of all our speakers have been posted on our site. Because of the time limitations, we felt this was much better so that everyone could have access to their analytic brief bios. Thank you.
Thank you, Professor Koursis. Good afternoon, everybody. I am very pleased to be able to join in this very interesting and socially profound roundtable. I wish to thank the co-organizers, Professor Koussis, Professor Leonis, Dr. Pitelos, and to say that my contribution and the thoughts I wish to share with you have to do with mostly conceptual and normative issues. And that is to say, I'd like to share with you some thoughts about not merely what the facts are. We should always take into account the facts, because our reasoning about action, this is what I would like to share with you. Action concerning public health issues on the ground of the current crisis, which is not merely a health crisis, but a crisis having many determinants, as Professor Leonis said, a syndemic. So we start by taking into account of what is the case, not merely in terms of scientific facts, but in the way that our scientific knowledge and our scientific evidence can be combined with certain other facts, social facts and determinants, in order to reflect upon the question how to act. But in order to act, we need practical reasoning, not merely explanatory and scientific reasoning. So my contribution has to do with this part of our integrated reasoning concerning public health in a pandemic, not merely the current one, because we're intelligent enough to realize that there may be more pandemics coming, and we're also prudent enough to try and plan to be prepared to face future pandemics and threats as well. Mutual dependencies. Well, yes, we have only realized too well that our fragility is a common human experience. Health services, in some countries more prepared, in other countries less prepared. Prioritization is a very important issue here, taking into account challenges to primary, secondary, tertiary prevention in care systems. Wider effects on population health beyond the current disease. And of course, this is a fact of life for agents like us, having to meet responsibly competing demands. Health, of course, is the foundation of everything else. Without health, there is no human life and there are no human beings. So it's a fundamental value in our society. And of course, one of the other things we have learned is that we cannot cope, we cannot control or face the threats which are global, all by ourselves, locally or alone. So we need solidarity on an international level. I'm afraid I cannot move my PowerPoint here. I don't know why. Could anybody help?
You could try taking your cursor out of the frame and
Yeah.
press on the gray area. And then if you go up where it says Προβολή παρουσίασης, if you press...
Could somebody do it for me, perhaps?
No, because it needs to be done in your screen. So you need to go to where it says Προβολή παρουσίασης.
Προβολή παρουσίασης where?
It's on the top. It's the fifth or no, sixth.
Yeah.
There it is.
Yes, yes.
Then you need to press αποτρέχουσα διαφάνεια, which is the second one.
Yes.
Perfect. And then it should, yes. Okay. Yes.
Oh, okay.
Perfect.
That's
Okay.
better. Sorry about this. So, speaking from the standpoint of bioethics, normative reasoning about what to do, what we ought to do, we have to think broadly. So that means that bioethics has to broaden its scope And here are the conceptual tools. Very briefly, I'll talk about them. We need new ways of thinking beyond the traditional divide between medical ethics, ethics of research, on the other hand, and public health ethics. We need to cross the boundaries. And of course, the boundaries are very porous anyway. That means we have to reflect upon normatively which principles are relevant, which priority these principles have, which secondary principles, that is norms, which values ought to take precedence, and which competing interests have to be taken into the picture. Of course, when we talk about public health interventions, we talk about types of actions, structures, and policies which affect population health. Some of those actions, policies, structures concern interventions and benefits regarding individuals. Some others, whole populations, but there is an interrelation, because even when we target particular individuals, benefits disperse among the population. So public health measures can be taken to be, and they are, public goods sometimes, but some other times not. That's not the important issue, because some measures, which are not public goods, for the containment of the disease may be rivalrous. For example, therapies may not, if we target, we give the therapy of the bed, the intensive care unit bed to one, somebody else might be excluded, and excludable, as I said, some people may be deprived for receiving them. However, both those which are targeted and not targeted to individuals or populations, or both, have dispersed benefits beyond their targets. They provide goods which are in the interest of all to have. Therefore, we have to think robustly, normatively, in the light of this background. Normative reasoning conditions. As I said at the beginning, principles are important, scientific and other evidence is also important, and robust argument reasoning. Here we have the co-application, I say from the start, of the fundamental principles, both at the individual and the population levels. There is a continuity here, and I use the same word as Professor Leonise earlier, integration. We need an integrated framework to think at both levels, the individual and the population level, and of course the micro, meso, and macro level, because they all form, regarding action, an integrated system. Normative reasoning, particularly now. There are different justificatory frameworks in bioethical theory, consequentialist. I'm very skeptical about consequentialist frameworks, where the grounding normative source is an account of the good. We have questions from which standpoint? Subjectively or objectively? If we go to an objective understanding of the good, well-being or whatever, we need to have some sort of scaling metric. There are many, many problems with transforming qualitative notions into quantitative ones. We may very well use this metric, but only at the beginning of our normative syllogism. It cannot be the last word. And then we have the action-based models. Grounding normative source here is an account of agency and of practical reason. And we have two ramifications. One is the rights-based approaches, very dominant in contemporary bioethics, talking about rights, having as an initial starting point of normative reasoning, who claims a right against whom. And then we have the obligation-based, where the grounding norm comes from obligations and not entitlements to receive. I think this third approach or framework, if you like, is the richer, the more adequate, and the more soundly philosophically grounded. I have no time to expand. Principles of healthcare policies. We know the bioethical principles here, they have to be polished and ramified and applied in this particular case. I'll very briefly mention them and say how they can be refined. Respect for persons. Needless to say, if we're to think ethically about our actions and our relations to each other, we cannot but start from these very important notions: respect for personality, its freedoms and its rights. The other side of the coin is called human dignity. Unconditional human worth. No harm principle related to the previous one. Justice, there are many ramifications and different conceptualizations, all very important in our discussion, including equity at the local and, of course, global level. Beneficence complements the requirements of justice. We cannot just merely live in a society which is just. We need something more than justice. Justice is what we owe to each other. Beneficence is something more, doing good to the other, even if the other cannot be a claimant of our goodness, our beneficence. And solidarity as an offshoot of beneficence, which exactly is what we are as human beings, social beings, interrelated, interconnected, sharing a good life together. An aspiration, the latter one. Now, refining and extending the scope of these principles, obligation to avoid infecting others. Of course, primum non nocere. Justice is a syndemic, so many factors. There are many threats due to the promotion of fear, panic, social stigma, discrimination against the other. We need normative rational reflection here. Protecting the vulnerable groups is absolutely vital. If one lesson we have learned in this particular health crisis globally is vulnerability. We are all vulnerable. The difference between those who are very vulnerable and us all is a matter of degree. We should bear that in mind. Distributive justice, and of course, needless to say, last but not least, environmental justice. And then there is a duty to treat. It refers to health professionals. Yes, they do. They have a duty of care as part of their profession itself. That has a lot of implications and responsibilities, including, for example, the issue of vaccination. A health professional should get vaccinated out of responsibility deriving from his very duty of care. And there is no question about that, normatively speaking, and solidarity, as I explained earlier. Individuals and populations, as I said, an integrated framework because they form an ethical continuum. Needless to say, respect of dignity, fundamental rights and freedom are fundamental to justice. Therefore, there is no rupture. There is no tension between protecting individual rights and social justice demands or demands protecting population health. I have to go very...
yeah, because we have...
fundamental obligations in place, fundamental obligations. Now, questions of proportionality have to be settled, but we have to be very careful not to take it too literally. Proportionality is a metaphor in normative thinking, in moral thinking, and trust is important and communication is important. Regarding the tension I mentioned, I want to underline this, and I need a few moments of your time to stress that there is no tension, and there should not be, conceptually speaking, not contingently, conceptually, normatively, between individual rights and autonomy and the common good. Going beyond the metaphor of proportionality, here are three consistency constraints which exactly guarantee the coherence between individuality and population health, individual rights and population health. Each right holder or claimant is to enjoy all rights. We don't enjoy rights piecemeal if we are right holders. We are claimants for all our rights. rights at the same time set standards for everyone. Everybody should be like us, should be able to enjoy our rights like us. And thirdly, and very importantly, the rights of each person has to be consistent with the action required to safeguard respect for those rights. Now, if we take all these three constraints together, they're formal constraints, we realize that there are limitations and qualifications regarding the implementation of rights, as you can see there. Interpreting rights, no metric. There is no metric for rights. That's my claim, my normative claim, but we need adjustment of various rights in order to cohere with each other, in order to align with each other. A right to health is a right for all. There can be no right to infect, injure, destroy others, since they would all undermine other similar rights. There is no right to violate the rights of others. So that's the demarcation. No conceptual tension if we think in the way I've just tried to explain between normative moral principles at individual and population levels. Health is a common denominator and makes us think and rethink how to care for each other. Here, we cannot but take into our account the need for environmental safety. Health justice and climate justice go hand in hand. A new politics of cares is needed, a renewed infrastructure of cares that allowed best protection, granting priority to the worst off. At the same time, investing in science research and public health tools and infrastructures. Last but not least, the need for public engagement, public debate to draw the sound conclusions, considering and reconsidering all the time our plans and our actions. Thank you very much.
Thank you very much, Professor Tsinorama. I think we have to move on to the next presentation. It was a very enlightening presentation, and we will have the chance to have questions from the audience later on.
Okay. Thank you very much, Professor Koussis. And after this very enlightening presentation of Professor Tsinorama, I feel it's an honor for me in presenting and introducing Mrs. Marilena Anastassaki, a PhD candidate, a public health and epidemiology researcher, with an important contribution in the development of health promotion unit next to CHEME, to Research Center of the university. Truly appreciate her important contribution. Mrs. Anastassaki has a strong involvement in many international and collaborative EC projects with a focus on epidemiology, public health, perception of risk, and healthcare modification behavior. And Mrs. Anastassaki will give an illustration of a recent collaborative project that the Clinic of Social and Family Medicine developed during pandemic period, with a focus on all of the key subjects that this conference is trying to analyze. Ms. Anastassaki, you have the floor.
Okay, thank you. Let me share my screen. Just a moment. Okay, here we are. So I would like to express my thanks to the organizers of this roundtable, Professor Koussis, Professor Leonis, and Dr. Pitelou, as well as to all the professors who participate in this roundtable. It's a privilege for me to be among you. Also, many thanks to the participants of this, to the attendees of this roundtable. And what we are going to do through this presentation is an overview of research projects that have been implemented in Greece as a response to the current crisis of COVID-19. And specifically, we're going to go through a population-based seroepidemiological study for COVID-19, a European project called Recover, an umbrella of projects regarding a technique called very brief advice, and finally, a collaborative and competitive project about COVID vaccination hesitancy, about educating healthcare professionals. The principal investigator of all these projects is Professor Christos Leonis from the University of Crete. And our question for overview is how can evidence and tools gained from such projects, which are multidisciplinary, can be translated to inform equitable public health actions during this crisis and beyond. So regarding the COVID-19 pandemic, the case for Greece is that the country is not among the most affected countries in Europe, but still we face a substantial burden with a dynamic evolution that has shown a rapid rise. Until yesterday, we had about over 3,800 number of cases, over 11,000 deaths, and over 600 people in intensive care. Crete is the island of the largest island of Greece. It's located in the southern part of the country, and until the second wave of pandemic, we were very much less affected by COVID-19 in contrast to the rest of the country. However, these days, during the third wave of pandemic, the number of cases has shown a rapid increase, and we have already reached over 10,000 cases in the island. Now, what seroepidemiological studies do is to estimate the proportion of a population that has been infected and developed antibodies against an infectious agent, in this case, the coronavirus. They differ from the traditional surveillance strategies because they estimate the true burden of disease, the true extent of disease, not only the proportions of patients, of people who somehow are identified by the healthcare system and registered as cases. People, as we might suspect, often do not reach the public health system, either because they don't have access to it, or for several reasons, including socioeconomic factors, but as well as in the current disease, because they are asymptomatic, they don't develop severe symptoms, and they never go to healthcare services. So these seroepidemiological studies are very relevant for diseases such as COVID-19, who have a long incubation period and a long asymptomatic phase. In the case of COVID-19, this proportion is estimated from 4 to 41%. Seroepidemiological studies are finally very important for predicting the epidemic dynamics, preventing further spread, because we timely identify hidden cases and we proceed to contact tracing. And of course, we can use them to design effective public health response. The population-based epidemiological study that we conducted in Crete, of course, aimed to estimate the prevalence of the new coronavirus by age, gender, and area of residence in the general population of the island. The project was funded by the region of Crete, and the design followed a repeated cross-sectional seroepidemiological study using protocols and methodology and tools proposed by the World Health Organization. We conducted the study in 3 phases in order to see the dynamic changes in the burden of disease through time. The first phase was between June and August of 2020, when the epidemic, the first wave of the epidemic had stabilized. The second phase was recently from November to December of 2020 during the second wave. And currently we are in the process of conducting the third phase under the third wave of pandemic. Our population consisted of a random sample of adult residents from the general population of Crete. We used stratified random sampling. Stratification was done by region, gender, age, thus giving us 24 strata. In order to select our population, our sampling frame was the civil record of Greece that gave us, this is a record of all citizens with some information of the country, and this gave us an expected sample synthesis by municipality of Crete. We totally have 23 municipalities in the island. And for each person that was selected from the sampling frame, we also selected two alternatives in case we could not find the selected person, with same characteristics, of course, the alternatives. This was a very, very extensive and coordinated action with following a strong operational plan, including very strong stakeholder engagement, because it was a large-scale study and very innovative in terms of conduction. So we engaged with a lot and different stakeholders, including the Ministry of Interior, for gaining approvals, for facing GDPR problems, for gaining access to the civil record of Greece. It was very important that we established a primary healthcare network consisting of more than 20 professionals that would help us conduct the data collection. We established data collection sites in each region, of the island. We had the involvement of a wide range of research assistants, from researchers to students and several volunteers, because this was a very large action. Of course, we engaged with municipalities to facilitate communication with the citizens and data collection. And we ran a relatively extensive media campaign in order to inform the public about the study, so that people who would be invited to participate in the study do not hesitate to do so due to lack of knowledge. Our outcomes were, of course, the prevalence of infection, the proportions of asymptomatic to subclinical infections, and several risk factors for infection, including socioeconomic and demographic characteristics. What we did was to identify the participants' contact details through public listings, make a telephone call in order to inform them and to invite them for an appointment to participate in the study, and perform the data collection by the healthcare teams. Our data, including not only epidemiological characteristics such as sociodemographics, medical history, symptoms, and contact and transmission history, but also, of course, serum sample from blood, in order to identify IgG and IgA antibodies. I cannot share with you the results yet, because we are running a comparative analysis of the phases of the study, but I can tell you that we had the participation rate up to 98% per municipality, but we also had several shortcomings and barriers that reduced our sample, the participation rate, and our sample eventually. These barriers taught us a lot, however, and they were related to GDPR and personal data concerns and approvals. They were practical and related to restricted information, outdated sampling frames. We had some problems in our collaboration with some stakeholders, and of course, a big issue that reflected the whole tendency towards denial of the epidemics was also the denial to participate in the study for several reasons. Now, in terms of discussion, what we saw from this study was that through this research, we confirmed for one more time that primary healthcare has a direct contact with the community, and this is the first point of care within a healthcare system. So it is crucial for the identification, the monitoring, and the control of local outbreaks in parallel with providing equal care provision, especially in Greece, where access to primary healthcare is free under the social security system. What we need to do, of course, in primary healthcare is to conduct and fund further epidemiological studies, train healthcare professionals on how to conduct data collection, increase their access to testing and diagnostic equipment, and enable the monitoring of cases over time through technology-driven applications. These are some examples of how surveillance strategies can be integrated to primary care. Such strategies include risk communication, which enables all people of a community, many people, let's say, in the community have access to quality information, testing and contact tracing, and as well as case management and transmission control. Continuing to the next project, which is entitled Rapid European COVID-19 Emergency Response, or simply RECOVER. This is a European project funded by Horizon 2020, and this is an umbrella project including several studies. We participate in a quantitative study, a point prevalence audit survey of presentation and management of patients with community-acquired acute respiratory tract infection in Europe, which is extended to include the COVID-19 situation, and qualitative research with patients and healthcare professionals. So the extending the point prevalence audit survey aims to describe the consultation characteristics and patient management for primary healthcare patients presenting with respiratory tract infection symptoms during COVID-19 pandemic versus pre-pandemic data. The design was a prospective observational study with the participation of 16 European countries. We followed an anonymous recording of patient consultation and management characteristics, including diagnostic testing, medication, advice, and referrals for patients with respiratory tract infections. We compared pandemic data versus pre-pandemic audits. The qualitative study of RECOVER aimed to explore the experience and views of primary healthcare professionals and patients with suspected COVID-19 symptoms during the first wave of pandemic. It was a qualitative study in 8 European countries, and we used semi-structured interviews with 66 patients and 80 professionals overall. We collected data on health-seeking behavior, delivery of care, perceptions of risk, and public health messaging. And the data were analyzed using inducive and deductive thematic content analysis. Several key messages were drawn from this project, and there is already one publication out, and we are currently writing 3 other papers. So we saw that European primary care showed a rapid responsive and rapid adaptation to the current crisis, but many new challenges arose, including changes in consultation style, remote consultations, and use of extra protective equipment, which may have resulted in professional burnout. We saw a large between country variation in consultation characteristics. We saw patients struggling with suspected COVID-19 symptoms, as well as the self-isolation measures, which had a significant impact on their emotional and psychological well-being. And what we proposed was that action should be made to support the mental health of patients and professionals, promote testing, messages to promote testing that should draw on the benefits of loved ones, messages for vaccination and prevention strategies that should explicitly address immunity. We saw that primary healthcare should be represented at the policy level by adapting services and providing ongoing training, which is in turn critical to preserve the ability for rapid transformation in future crises. And finally, we concluded that multi-country and real-time audits may help with fine-tuning a national action plan, but also coordinate a unified pan-European response. Continuing our projects, I'm going to talk to you about the very brief advice project. This started as a project for smoking cessation, but these techniques that this technique employs can be used to facilitate other diseases as well and other health situations, because they provide the ground for delivering short and cost-effective interventions with patients with minimal burden for healthcare professionals. So very brief advice on smoking is a very simple form of advice designed to be used opportunistically in less than 30 seconds in almost any consultation with a smoker. The research questions for this project was whether we could adapt this technique in the healthcare context of Greece, and whether training general practitioners in VBA can result in changes to self-reported confidence in delivery and practice. The senior investigator for this project for Greece was Dr. Sofia Papadakis, and I have to say that this project started from a bigger program, European program called Fresh Air, and then was funded by future projects. Sub-projects were funded by the National Center of Smoking Cessation and Training of the United Kingdom. What we did in Greece was a mixed method study. We adapted with quantitative and qualitative elements. We adapted an existing VBA training, and we proceeded to a train the trainer module, where we trained healthcare professionals, GPs, who then delivered VBA in their daily practice. What we saw were significant improvements especially in providers' confidence with advising their patients in the best methods for quitting. And also we saw improvements in the confidence of providers to act based on the patient's decision to quit smoking. These changes were significant, both when comparing before and after training practice, and as well as when comparing pre-training practice versus 3 months following the training. So the very brief advice training was well received by general practitioners, as well as by patients who received the training. It was influential in terms of provider self-efficacy, and it was, of course, motivational for patients when delivered in a supportive and caring manner. The questions here are how we can sustain this project and expand it to include other professionals, how we can assert it as an educational standard for primary healthcare professionals, and how we can integrate this project to health policies as a cost-effective strategy. Our next steps include a similar training on very brief advice for second-hand smoke. Following the same philosophy of VBA, we developed another project about enhancing the skills for addressing vaccine hesitancy among medically undeserved and economically deprived people in the island of Crete. This project was funded by Pfizer Competitive Grant Program. And the objective of these projects are to understand the perceived factors that enhance the willingness for vaccination or contribute to COVID-19 vaccine hesitancy, to adapt the knowledge on addressing vaccine hesitancy into a brief e-learning intervention for primary care providers and to support professionals in providing outreach to deprived individuals and families to enhance vaccination uptake. What we are expected to see through this project is, okay, it is the first project to adapt a training intervention to assess vaccine hesitancy among residents in Greece in parallel to the current population-wide vaccination strategy. We're going to use technology-based teaching modalities and video modeling and evidence-based teaching techniques to enhance the skills of healthcare professionals. And we're going to adapt existing evidence-based behavior change and counseling techniques with proven efficacy, such as very brief advice and motivational interview, to address COVID-19 vaccine hesitancy. One of the most innovative aspects of this project is that it focuses on deprived populations who are expected to have, of course, limited access to healthcare services and vaccination, to be at risk to develop severe disease, and to be at higher likelihood of vaccine hesitancy. In conclusion, we, as many organizations, world organizations, have highlighted, integrated and equitable care encompass public health, primary care, and evidence-based practice to enhance the factors that encourage health, to enable health equity by addressing the social determinants of health, and to mediate to achieve collaboration across all sectors. We see that effective response to COVID-19 requires a quick and large-scale reaction to connect health and care systems and enable collaboration across different settings and disciplines. Research and capacity building efforts, such as those described before, show how to best design and rapidly test the evidence-based approaches for the operationalization and implementation of integrated care in order to address public health priorities, improve population health and well-being, and support the evidence-informed policy making. These are some core publications of our team from European projects that can show how research can be used to respond to the current crisis, as well as to other fields of health. And closing, I would like to say that I really like this quote that today's world is truly a global village, and maybe we need to develop the solidarity and sense of coherence observed in traditional villages, especially here in Greece, in order to tackle this and any future health crisis. Thank you very much.
Thank you very much, Mrs. Anastasaki. You provided an illustrative reflection and information about the current project already developed by Health Promotion Unit in the next to KEME. And then we keep in your conclusive remarks later on when just discussing the questions that we have prepared with the Professor Kousis. Professor Kousis, your floor is yours.
Thank you very much, Marilena, for a very informative overview of your research projects on COVID-19 and all the teams involved in Crete. Following the presentations by Stavroula Tsinorimou, Professor of Philosophy and Bioethics and Director of the Joint Postgraduate Program in Bioethics at UOC, Marilena Anastasaki, Doctoral Candidate in Public Health and Epidemiology at UOC, we move to the next presentation by Professor Evangelos Karadimas. He is Professor of Clinical Health Psychology, so we move to another discipline. And he's also the director of the Applied Psychology Laboratory, as well as the president of the European Health Psychology Society. Evangelos, we look forward to your presentation.
Well, thank you so much for the invitation, and thank you all for being here today at this time, which is the starting of another spring/summer weekend. And I hope that you are rewarded by attending this symposium. I will really try to be as brief as possible, to keep it less than 10 minutes. So as agreed, so as to give more time, allow more time for discussion, questions and answers after all presentations are over. So the focus of my presentation is just to emphasize the need to use human behavioral research in order to inform all these public health and health policy initiatives. You see, research in human behavior, such as self-regulation, which is how the person understands and what they do in order to deal with the stress. For example, the stress coming from the pandemic, and also dyadic-regulation, that is what partners and families do in order to understand and also cope with this unwanted and undesirable condition, is really crucial, because knowing human behavior and understanding human behavior, we can just translate this knowledge into specific measures that we can take, we can implement in public health initiatives. And to be honest with you, there are a growing number of thousands of studies, not just for this pandemic, but also for previous pandemic. For example, there are more than 2,000 relevant papers about the H1N1 pandemic, more than 10 years ago. And the aim of this research is to understand the mechanisms that drive human behavior or hinder, let's say, the governmental endeavors to take measures that will prevent infection. I will focus just on a couple of Greek studies, because we're talking about Greece. And I will try to show to you how the results of these studies can be translated into public health initiatives. So this is an international study that was conducted in 2020, from March to July 2020, and the participants were coming from 27 countries, one of which was Greece. The study was cross-sectional, but it was also a qualitative and a quantitative one. So as far as the qualitative data is concerned, we have data from more than 9,000 persons, 600 of which were coming from Greece. And we found that there are 5 major themes that reflect individuals' concerns about the pandemic. And these 5 themes are concerns about their personal and close persons' health, challenges for the existing challenges for the interpersonal relationships, that is, we are stuck in our house, we cannot get in contact with other persons, we are isolated and things like that. Insecurity about the future, and especially about the financial future, how the world is going to be after the pandemic is over, is our, let's say, ability to work will be needed in that world, and so on and so forth. The fourth themes about the issues that are related to the society and the others might be the scientific community, might be the government, or even the media. Many people, especially in Greece, from the very first moments were very reluctant about what they heard in the news, and they didn't trust, let's say, governmental decisions. And that's a difference because we found that mostly in Greece and some other countries, let's say South Korea, but not in Germany or Italy or United Kingdom. And also there was a strand of people who said there's no problem. We don't understand what you are talking about. This is not a pandemic, this is just the flu. It's the name of the typical flu or something like that. So you don't have to worry about that. And we do not worry about that. And especially with regard to Greece, as I said, there's this trusting issue with others, like the scientists and government. There was more emphasis on issues that were related to social isolation, and also some concerns about the economy. And the latter is explainable because we just came out of over a decade financial crisis. The same study showed to us that family, that is the support coming from a family, or the behaviors that partners employed in order to cope with the pandemic, that is, support other members of the family, or take care of their needs, or try to soothe their emotions and things like that. Let's say supportive dyadic coping, supportive care of the other members of the family was really, really significant. And that was especially significant for Greece. Greece was the country with the most, let's say, strong relationship between positive dyadic coping and the positive effects of family, let's say. And on the other hand, it was one of the countries with the greater impact of the negative dyadic coping, that is criticism or not being able or available to help. And we see that in Greece, positive dyadic coping is very helpful, more helpful than in other countries, and also negative dyadic coping, that is criticism and not being able to help or available to help, seems also to be very negative for the population's mental health, because the focus of this in the study was mental health. Also, something that was just for Greece, it was, let's say, a smaller study incorporated in the big study. And the emphasis there was also on psychological symptoms. And we found that there are three, let's say, psychological variables that are really related to the psychological symptoms developed after the beginning of the pandemic. And these were the representation of personal control over the situation. That is, if the person was thinking that I can do that, I can just follow the measures, I can just go through this situation, and I will survive. I will do my best and I will survive this condition. The second psychological variable, which was very closely related to psychological symptoms, of course, in a negative way, was self-efficacy. Self-efficacy to cope with the measures that were taken to prevent the infection. That is, the persons who said to everybody, yes, I can do that. Yes, I can wear a mask, a face mask. Yes, I can wash my hands. Yes, I will take a vaccine if that's available. And also the third factor that was positively related to psychological symptoms, that is, it led to more psychological symptoms, was emotional reactions to the condition, that is fear. People that were afraid of the condition were also reporting higher levels of psychological symptoms. However, in another study that was also conducted in Greece and Cyprus, and they used the same measures as we did, they found that, for example, the representation of personal control, if the person said that I can deal with the situation, on the one hand, yes, it was related to fewer psychological symptoms. But on the other hand, it was related to less good adherence to preventive measures such as social distancing. So it seems that the belief that one is able to deal with the pandemic in a successful way, it's, let's say, relieving, makes the person think that there's nothing to be afraid of, or does not lead anyway to psychological symptoms. But on the other way, they can also lead people to believe that there's no need always to follow the preventive measures. We can just manage it without being so strict with the measures. So the question is, how can we take these, let's say, findings and translate them to public health? The answer to my mind is that we can definitely do that. And that was the case not just for this pandemic, but also for other health crises in the past. Of course, we need to, let's say, combine these findings with modern relevant theories, and that's I think the crucial point. Modern theories that they can explain the modern society and the modern, let's say, human behavior, and theories that are relevant, not theories that just refer to human behavior in general, but theories that refer to human behavior with respect to health crisis. For example, we found in this study that the important others, that might be the partner or the parents or other members of the family, this important others behavior is really important for the behavior of everybody. So it might be translated to a point that might, let me rephrase it, please. This point was that probably if we build up a prevention measure or a prevention program or a public health measure that is aiming in helping people understand the dangers of being infected and things like that, probably we shouldn't focus on persons, and I mean in Greece, probably we should focus on families or on dyads, that is couples. Probably it is the familial bonds that make a person more, let's say, be able to think proper and also behave properly in a way to protect themselves. And this dyadic support and this dyadic coping is probably a point that a future public health program should focus on. A second point is that we should provide information about health policy decision-making, how we make decisions. We saw that from the beginning, from March 2020, many Greeks did not, let's say, believe, or they didn't trust the way that policy was made. They didn't trust the government, or they didn't trust the scientific bodies. That probably has to do with, let's say, our culture, probably has to do with the recent financial crisis, or probably has to do with the current pandemic. But in any case, we should be very careful and explain why we make a decision, how we make the decision, and what we aim to. And these are probably some issues that were not very well taken care of during the last pandemic. There are non-variables such as self-efficacy or representations that are really important, and they have been used in several programs in the past. So we can also use these variables in public health initiatives. For example, if we try to strengthen people's self-efficacy or to modify their representation in a way that they can lead them to follow the measures and also feel more safe, then that would be a great success. And also we should focus on a group of people that seems to be a constant finding throughout studies, that there is a group of people who cannot really accept reality. And we don't know many things about these people. For example, there were some psychological explanations that people are tired of the measures. But if you ask me what tiredness means about following the measures or not, I wouldn't be able to explain to you anything. So I think that we should, let's say, go deeper and find out what this group of people consists of and why this group of people is so persistent in their beliefs. There might be some psychological reasons, for example, coping mechanisms that explain their behavior, but there might be also some social or other reasons that we should know. If we don't know why these people are there and why they keep up their behavior, then we really can't do anything about public health. So if we take these, let's say, findings and combine them with modern theories and public health theories, then I think that we will be more able to guide behavior and promote well-being during not only this pandemic, but also in other health crises. The question is, do we do so? And I'm afraid that the obvious answer is not. And I would like to finish with that. As far as I know, there is not even a single expert in human behavior that participates in the committee that takes decisions about the measures that should be taken in order to prevent the infection. And all these measures explicitly refer to human behavior. So in my mind, I cannot reconcile this. How a person, how is it possible to take decisions about human behavior without asking the experts on human behavior? Thank you very much for your attention.
Thank you very much for a wonderful presentation and a well-targeted end of the presentation with all the implications, very important implications. Thank you, Professor Karadimas.
Okay. Yes, I think that Professor Kousis and dear colleagues, on Crete, but not only, we have discussed many times the secrets of Crete, and many, even in the medical school, consider the health, the social networking as a potential asset or as a positive issue. And certainly during the pandemic, we have not the chance in discussing so very much the perception of risk, and also not just giving so much evidence on the strongest component of perception of risk, which is the emotional component. And I think that at the moment we have been one of the best colleagues and who has a lot of many contribution on emotions. When having a Professor Kafesios from a university, Aristotle University in Thessaloniki, but also still a visiting professor at the University of Crete. Professor Kafesios has is a writer of many books relevant to emotions and social and personal relationships, and also currently is a current editor of the European Journal of Social Psychology. Professor Kafesios, we anticipate in giving us a lot of information about this is still in the medical faculty is not, or not a discussion. There is an emotional component of perception of risk. Yeah, the floor is yours. Thank you.
Thank you very much, Professor Leonis, for your kind words. Professor Kousis, Dr. Petelos, for organizing this symposium. It's a brilliant opportunity for multidisciplinary, interdisciplinary dialogue. And COVID-19 has, of course, tremendous, disastrous effects on our lives, but nevertheless, it gives opportunities like this. And as I will try to show you in a moment, it also gave us some opportunities to delve into some aspects of human behavior that otherwise we wouldn't be able to. Now, as Professor Leonis just introduced, the aim of my talk, the topic of my talk is on social networking and as a health risk factor, as both as a benefit and as a possible risk. And I will share with you also some data we collected during the pandemic last year and try to wrap it all up within the framework, the meaning of social networking in social health and other terms. Now, I start with a very well-known notion in, at least in psychology, in health psychology, in social psychology. The notion of social relationships and social relating is really an important element of health. This is a classic study, longitudinal study of elderly that actually demonstrated that social integration and social relationships are really the most important risk factor for longevity. Now, taking this into consideration, well, in terms of from a socio-psychological perspective, there are two main organizing systems, at least the ones we consider as central. The one is a cultural system, the cultural system of that is shaped from history, economy, and one of the main dimensions there is independence, interdependence. I will just describe it in a second. The other system is a behavioral system, and it's an evolutionary shaped system. And usually we wouldn't think about it in terms of group or group level, but recently, the last few years, it seems to have an immense effect on group behavior. And that's what I will try to maintain here. So my presentation targets those two systems and how they can influence social networking and social behavior, especially relating the COVID-19 era. A few words about the two systems. The cultural system is a cultural understanding of the self. On the one hand, we have the independent self. The independent self, the agency of the self comes from the self outwards to the group. Yeah, that's you can find it usually in Northern European, in more industrialized societies, and is associated, this is the critical thing, with weak ties networks. So independent social networks are weak tie. The emphasis is more on social relations outside the family or the close group. I must say here, parenthesis, many of the things that my dear Professor Karadimas was saying is really dovetails with some of the things that I'll try to share here with you. On the other hand, the interdependent system is the strong tie system. The emphasis is from the group inwards, from the group to the self. And the organization is more around the family, about the close ties, relationships, etc. And we know that very well from our culture. Our culture is a more interdependent culture, a strong ties culture. Of course, there are benefits and costs in both cases, but we will see to that now. On the other hand, the behavioral system, the attachment organization, is a behavioral system of threat regulation. It's developed by nature. It characterizes the human beings, but not only, the primates as well, but only them, dogs, dolphins, you name it. And there, recently, that's what I was saying, we wouldn't think about it in terms of groups, but recently, we came to appreciate the organization of attachment in terms of strong ties and anxious groups and weak ties and avoidant groups. So you can see a coincidence here between the cultural system of independence and interdependence and the attachment system, a group organization system of anxious groups, which tend to be interdependent groups. There is a correlation between the cultural level and the attachment level, and the avoidant groups, which you tend to find them in more independent, more industrialized societies. So there is a correlation between the two systems. They're not on the same level, but they interact effectively. Now, weak and strong ties, there is a tons of literature in health sociology, in other areas, in biology even, that the effects they have on the structure of the systems and how the structure of the systems can, in fact, influence behavior, including, of course, health behavior and well-being. Now, recently, there is also a very recent publication, a very nice and interesting theoretical review by Strand, that the two systems, as I just said, the cultural system and the behavioral system interact. And in fact, what Strand says, it's quite revolutionary, is that the behavioral system is underneath the cultural system. Up until now, we thought the otherwise, that it was the cultural system that influences the attachment organization, but his argument is quite nice. We don't have much evidence about that, but it's an interesting point. In any case, the two systems interact with one another. Now, what we did, I think everybody was so much, especially behavioral scientists, were so much amazed by, negatively enthused by the COVID-19. So we dug into the data from Oxford Global Change website. We downloaded longitudinal data from the very start of the epidemic up until the end of April. We used a formula 30 days after the 100th day when a case was observed in each culture. And we downloaded data for 53 cultures and 50 US states. Now, we were lucky enough that for the last 20 years or so, there is a website that collects data on attachment on the behavioral system from many, many countries, so 81 countries. But we took 53 because this was the more valid data. And then we had also per country cultural orientations. This is data from 2001. I must say, again, that the outcome data, the COVID-19 data, is from 2020. The attachment data are roughly from 2010, and the cultural data are from 2001. So there is, each decade gives us different data. We combine this data together. And what we ran a multi-level growth analysis. So over the 3 months of cases in these 53 countries and 50 US states, how did the attachment system and the cultural system predicted the prevalence of infections and deaths at the start of the epidemic and during the epidemic? And what we found, which was quite very interesting, as you see here, this is the start, the half of the table is the start of the epidemic, and this is the time slope. This is while the measures of lockdown happened. So what we find that cultures that are high preponderance on avoidance had a higher initial start of infections, where countries that are high on anxiety had a low count of infections in the beginning of the epidemic, in the first days of the epidemic. Individualism also predicted that and interacted with avoidance. So countries that were high on avoidance and individualism, this is here, had an even higher infection and death rate. Now, during the first 3 months, the picture actually turns around. It's exactly the reverse of the beginning. The countries who were initially low on anxiety, they started getting higher infection rates. And this was something, it's difficult to interpret it, but there is actually recent publications, one of them in Nature, by a Chinese group that actually demonstrated that in cultures which are more family-oriented, etc., the measures of restriction actually affect them more because the in-grouping, the family system actually made it worse. So we had this picture, and it's very similar if you look at it within a cross-cultural context, 53 countries, and within the 50 US states. So at group level, you see an interaction between the attachment organization and the cultural organization. This is a paper which is currently under review. And something we are currently preparing for publication, and it's also the child of all these observations and work. I must say again that normally I don't do this kind of research, but the data is really intriguing, and the data is behavioral data. This is the difference from other types of data we had before. It's not about what people say they do, it's what people do. And this is the very interesting thing. So we looked at these 53 countries again, and we predicted the life expectancy according to 2017 indicators. And what we find again is that avoidance, the average level of avoidant organization in a culture, negatively predicted life expectancy. So avoidant countries are low on life expectancy. We're trying really to tear this apart, to understand what's the mediating mechanism. We're expecting that there's some kind of social networking of avoidance, but we don't know what age group is this happens. It's difficult to find the data. Some colleagues are not very great. They're not very willing to share the data, but we're trying. And then we also found a very interesting interaction between the Gini index, an index of inequality, and anxiety. So in countries who are high on equality, anxious groupings, in-group groupings, family groupings, also have a negative effect on life expectancy. Again, we don't know exactly what this means. We have some notions, and we are still trying to tease it apart. So all in all, this is what I want to share with you, is some insights we got from the COVID-19 situation. And there are some interesting ramifications of those. Is the age differences in the culture and attachment determinants. We do know that as people grow older, they do become more avoidant and they do become more independent. It's a paradox, but that's what happens. We also know that in cultures who are more interdependent, there is a different type of proportion of social networking. More interdependent, more perhaps anxious interdependent countries, people put more emphasis on not on behavioral level social networking, but on implicit social networking, talking to people or communicating through the media. In that respect, this is an interesting thing also to discuss in the context of the new emerging technologies. So these are the questions that I kind of pose here, that how the new ways of connecting may impact differently groups, organization, cultures that are structured weak or strong ties, anxious, avoidant, independent, interdependent. Thank you very much.
Thank you very much, Professor Kafesios. Your presentation offered many thoughts in seeing further collaboration. I think that we needed, that is one of the results, I suppose, of this interdisciplinary meeting, in thinking more how to collaborate and co-work together in the next period in the post-COVID-19. And I suppose that your presentation offered many illustrative thoughts. Professor Kousis, you have the floor in presenting Dr. Petelos.
Also to Professor Kafesios. Professor Karadimis, you have a question, or you just...
No, that was not. I was not raising my hand. I was clapping for.
Okay, sorry.
It's a digital clapping.
Thank you. Our next presenter is a public health specialist, a research fellow at the Caffrey Care and Public Health Research Institute of Maastricht University. Dr. Elena Petelos is also a lecturer of EMBM and EIP at the University of Crete. We welcome her and I look forward to her presentation.
Thank you for the kind introduction and also for going into the trouble of organizing something for Greece, because sometimes we see Greece as far away from what's happening, let us say, in European things. And also, I'd like to say that I will try, because I saw Professor Tsinorema having some technical issues. So what I'm going to do is I'm going to try and switch off my camera so that we don't get the same issues, but switch it back on after I've wrapped up. Okay, so sharing screen. Desktop. Hopefully you can see my screen. Cancel and here we go.
Yes, we see everything.
Perfect. So I am indeed affiliated with Crete and with Maastricht, but I have different hats, and I'm actually I'm the acting chair for Sustainable Development Goal 3 for SDG 5 at the European Public Health Association. And I'm in the steering committee for public health law and for infectious diseases, plus the vice president of HTA. There are some affiliations here just to avoid potential conflict of interest. So I would like to discuss a little bit further about the challenges on assessing vulnerability, which was mentioned by many speakers, and of course, combating inequity. A concept, particularly the concepts of information and evidence, which are two terms that were heard quite a lot in the previous presentations, because these two competence may be interlinked, but they're not identical. They're far from identical. Data is, of course, a common denominator, and we do need to emphasize the need for high quality data to generate evidence. And without a doubt, in this ever-changing global village or landscape, we do need to consider the infrastructures for generating high-quality data and for exchanging it. And that includes research infrastructures, and I'll come back to that. Because otherwise, evidence synthesis, which is useful, be it context relevant or of cross-border relevance, to shape policies and actions in a manner which is not just effective or relevant, but also timely. Publishing results a year or two later is rather irrelevant for policy, plays a very big role. So having a systematic and timely collection of data we actually need is also very relevant for identifying who's most at risk and whom we should be supporting. And the concept of determinants has been prevalent in discourse across disciplines for many years, but has not really been embraced as it should in policies, be it geographical, economic, and for other reasons. More specifically, I'd like to stay for a few minutes on the concept of vulnerability and determinants, because vulnerability is not only determined by biological factors and is not to study it comprehensively, let alone to address it. We do need to capture data and to inform key determinants, and particularly how they are at interplay with each other. So composite indices get generated, and how this may impact upon rendering a person or a group of people or a community, or even, as we have seen in the context of our country, even a nation or a region more vulnerable. So we also need to consider something which had the pleasure and the privilege to discuss extensively with Professor Leonis over the years, and I was glad to see Professor Kafetsios briefly, I think, mentioned that, and Professor Kardimas briefly mentioning behavior in psychology, because there are such things as protective factors which may confer or confer some protection or counter effects, particularly in a crisis. And this could be family, could be social networks, could be religious beliefs, but there could also be structural measures that are dealt with in the context of social justice, such as financial protection mechanisms to ensure stability, and an extensive frame of health, and not only in social care. So what we do have common across the world at the moment is a growing congruence between countries progressing and growing with what we call exponential technologies, not only the internet, but also AI, artificial intelligence, and RWE. But what we're seeing the same trend when discussing policy across countries, and that is a widening gap between those really at the bottom, if you like, of the socioeconomic strata and those at the top, with very few people actually benefiting from the advances we are experiencing at the moment. And this also represents a very concrete danger for further polarization in our societies, with whatever this may imply. Now, there was a nice presentation by Dr. Anna Sasaki, and she was trying to show what we have been trying to do at CSFM, working in the field with perhaps piloting exercises or collecting data and so on. And I think Professor Leonis in the beginning mentioned the concept of syndemic. Traditionally, for the past 30, 40 years, we've been seeing a growing trend of studying non-communicable diseases distinctly and separately from communicable. And what COVID has made starkly clear is that that is not a very robust scientifically approach, because in terms of combined effects, non-communicable diseases, social determinants, and COVID are largely at interplay. So this is from a colleague, Claire Bamra. There's currently a workshop being organized for the European Public Health Conference in November, where we would like to look at the different factors, starting from the very center of looking at families and health-related biological traits and even practice in communities, and moving forward to social and community networks and other social determinants like education or access to services, the environment, and political and economic conditions. And have to say that progressing very quickly, and as we've been seeing, for example, with new technologies, PLFs, potential digital vaccination certificates, and so on, offers a great opportunity. But as Professor Tsinorema said, poses very concrete normative questions, and whether we should be dealing with them under utilitarian perspective or not, because from a decision-making and political choice, it actually represents a very high degree of uncertainty. And data collection there, to be timely, doesn't really help much. So we need more concrete networks beyond the pandemic to study the populations and to know how people behave and what determines that behavior. There's also a very critical aspect in these key determinants, and that is the governance and the deliberation that may be there. So deliberative mechanisms We do have the internet, which allows for more participatory, co-creation, or co-design approaches, but the different social determinants that interplay. And although people that previously did not have a voice may now have a voice for participating in different activities, in different consultations, in different decision-making processes, we are still very, very far away from actually having a very representative, let us say, participation of our populations, particularly across the globe. In Europe, perhaps we're a little bit more privileged. Language is also a barrier. And I have to say that when we were preparing this with Professor Kousis, I was going to speak more broadly about what we've been discussing in European settings for policy, but I decided to focus particularly on gender, because we are seeing many, as I think you've seen pretty much every presentation slightly touched upon this, we are seeing COVID really bring to the fore all the things we knew were there, but perhaps didn't study as we should. So critically, and for many years, women have been unequally affected by the burden of caring for others, both as formal as informal caregivers, and because of the interplay of other determinants that could be biological characteristics, social constructs, and then the concept of intersectionality comes at play. So the combination of different factors. And in this indeed global village where disease has no border, we have had a case where previously we had focused on goals, broad goals, millennial goals, where we were looking at the developing countries, but with the advent of the Sustainable Development Goals, we really moved forward to discuss women with a very specific goal. So for those of you that are familiar with Sustainable Development Goals, of course, we have Goal 3, which is focusing on health, supported by 13 targets to ensure healthy lives and promotion of well-being for all. And of course, there's explicit mention to immunization campaigns, to women, to sexual productive healthcare. But that statement, the bold statement of leaving no one behind, which is and universal health coverage, which is what we celebrate today in European Public Health Week, is very closely linked to SDG 5, which is gender equality and empowerment of women. And in 2019, revisiting the universal health coverage in the high-level forum in the UN, all of us that were there were very, very excited to see a very clear focus on women. And out of the civil society mechanism, there was a bold statement asking for a radically different approach, prioritizing gender equality and girls, and giving them the tools to actually participate more and be on a basis of equal footing in terms of rights. This is also particularly relevant at the time for COVID, as we see reports emerging from across the board for gender-based violence, for an exhausted workforce, for mental health and physical health issues, particularly important for the healthcare workforce. Because as I think previous speakers mentioned, women represent 75% of the workforce, and we have, again, both formal and informal caregivers. And then in terms of vulnerability, we have to say that we've seen a massive rise in gender-based violence. And we go to the point where we're saying that we don't just need to provide equal access, but to prioritize the access to health and social care for women and for girls, to prioritize potentially vaccination, whilst at the same time ensure there are governance structure for safeguarding the rights, and particularly where there's intersectionalities at stake, those of the most marginalized. So in terms of data, going back to our more traditional realm of EPI, disaggregated data is key for all determinants. And there is strong determinants research, including for COVID, because we're over 20,000 publications on related topics. Women are central to filling the 18 million additional healthcare work jobs that we have for UHC, which you see doubling at the moment with extra work for COVID. And whilst women at the same time only hold 25% of global health leadership positions and generally have lower status and lower pay and even unpaid roles, particularly in structures, employment relations, which are not necessarily well formalized, and this means they cannot usually afford the same social protection. So there's also the aspect of saying, I think we touched upon this a bit, of actually having people, women, marginalized, vulnerable, participating equally in a society. But having said that, to do that, people should be able to have the right tools and the right information and to feel safe. And going back to Professor Tnerema's point, trust is key for people to feel safe to provide their data, because health data is not simply private, it's sensitive data. We have the right to be forgotten. For cancer patients, we have issues of privacy, and we have issues of potential secondary use of data, which actually, even with those of us who are involved with artificial intelligence and machine learning, we have difficulty in seeing which framework we would be using from a perception of ethics. So going back a little bit to gender as health determinant, these are not news. These are old concepts. I mean, what you see here was approved in 2007 in the WHO, the World Health Assembly, and then revisited in 2019. But then one would wonder why we're lagging behind. Because systematically speaking, collection and use of quantitative and qualitative disaggregated data is really not there. Not globally, not for Europe, because understanding and analyzing differences from gender analysis is equally lagging behind, and because gender responsive policies and interventions have not been prioritized. And that potentially corresponds or links quite well if one looks at the EIGE, the European Institute for Gender Equality, to where women hold political leadership. Because we had gone a little bit over time before my time, and to allow some time for discussion, I would like to emphasize 3 points that we had previously gone wrong, because primary care is key and should be funded, but it doesn't necessarily address all determinants that are interplaying, including socioeconomic ones. It's a remedy and should be utilized for prevention, but other decisions are needed there. And of course, it's critical to say that for today's policy recommendations, we do have enough large body of evidence to do that. And this is from 2 hours ago, because today this potentially even compromised a little bit our activity here, because we had for the first time the G20 and the European Commission convening the first Global Health Summit, in which the European Public Health Association was participating in the context of civil society. And the final documents are out. And if you look at them, these points have been highlighted. So women and girls have been disproportionately affected. We do have the data for that already. Resource allocation for UHC in primary care, particularly for where you have intersectional cases of women and elderly women, young women, migrant women, refugee women, and also LGBTQI and other marginalized groups. They're also disproportionately affected. And we've seen that weak public systems have favored emergence and transmission. So systemic problems that we all recognized. To go back again to Professor Tnerema's presentation, we do need to move forward from global health security, which is a very important thing, to a concept of aligned values and a very comprehensive ethical frame on a human rights-based approach for global health solidarity and gender equality. There's also a call for technical support, because otherwise we stay with rhetoric. I have to say that it's difficult for researchers, including for myself, to delve into policy making, but it's quite nice when you manage to come with colleagues across Europe to discuss and call upon concerted action to find your paper trending in German Twitter and media, because the Minister for Research and Ministry for Health in Germany think it's news and it should be actioned upon. Which does generate a lot of flack in some circles, but which has to be done, because we also have to go as researchers, academia, beyond our comfort zone. And again, the elderly are very important for Greece, for the social cohesion of families, but also for the whole of Southern Europe and perhaps globally. And we have seen that they are really disproportionately affected also from lockdowns. Now, these are the documents that have come out for pandemic preparedness from the summit, and it has been streamed. I would like to close on 2 points and 2 notes to say that Crete is also participating in activities which are linking health information exchange to population health for COVID. FIRA is the Population Health Information Research Infrastructure Project, which aims to bring together national nodes from all countries. So not just discuss data from, to touch on the previous presentation, where is the data? So we're trying to get the data going together. And there is, as some of you may know, there is TDAS. So there is a joint action towards the European health data space. And CRIT and LP and University of Thessaly are participating in the first couple of activities, and I think it's the sixth region for us that's participating in TDAS. But we all come together on the 31st of May because the health information and data exchange portal, the health information portal, which is a one-stop shop, is opening, and it will be accessible to any researcher, any citizen. So the data sources, the data providers and data managers should and could be able to use it. And we are in the process of establishing a distributed infrastructure for population health to see whether it's possible to come together as a Europe and make cross-border, cross-relevant, interdisciplinary and cross-sectoral policy decisions. That's it. I would like to say that in my last slide, I have embedded a link because you can also find it by Googling on YouTube, because yesterday, it's been a very intense week, because yesterday the Health for All Film Festival from WHO for Universal Health Coverage was completed. And there are some very, very, very nice films out there on YouTube touching on many, many issues, including on gender equality, but not only. Thank you.
Thank you very much for such an inspiring presentation with lots of information, especially all the most recent developments. Thank you, Dr. Patellos. I will give the floor now to Professor Leonis to start a roundtable discussion, but I see it's 5 to 6. We are quite behind in terms of time, and I would propose to instead of having all the questions on the floor, we limit them to Professor Leonis. How many would you propose?
Yes, already we have formulated a couple of questions, but unfortunately not so much time. And I think that we have in 2 key questions already addressed by Mrs. Anastasaki and Dr. Patellos, and I'm strongly suggesting in consider the 2 general questions. The first already we discussed and raised by Mrs. Anastasaki. What are the challenges of translating the knowledge into public health actions during the COVID-19 pandemic? That means it is nice having a response from all the speakers. How does it translate learned issues at the moment, just and focusing and raising suggestions and during a pandemic? And the second, as Dr. Patellos already has discussed, to what extent at the moment that health technology could be also an evidence-based, it could offer a new ground at the moment and new evidence to policy makers. I think that's the 2 questions. That's the first is how all of those learned could be translated into public health actions, and the second, to what extent the technology at the moment could just assist the new efforts to the post-COVID period. I think that's the 2 questions. If you agree in asking all the participants in giving their reflections.
I agree, because then we also need some time for any questions from the floor.
Yes, and we can start with Professor Chinorema and then continue with the same series that we followed. Professor Chinorema, yes.
Thank you, Professor Leonis. Regarding the first question, I think it's a very important one. Yes, indeed, one of the very important prescriptions during this pandemic has been, and rightly so, follow the science. But then, if we want to move on to public policy, we cannot do it directly or reductively, because public health decisions, on the one hand, of course, needless to say, should be evidence-based, including based on data, but at the same time, they cannot merely be determined by those, because always they involve value judgments. which, of course, value judgments are not merely a matter of explanatory propositions of science, but they can and should be dealt with through normative reasoning. So here I think it is very important for us to be very clear about our conceptualizations of values in an integrated way, in a way in which they don't appear to be clashing against each other, because then we come up with dilemmas which are really superficial at bottom. And this has been my intervention here this afternoon, to explain why conceptual clarity and normative thinking and robust reasoning can sort out these things, how we go from scientific evidence and data to policy decision making. In the middle, there is a question about action. So we need an interdisciplinary underlying theory of action. Thank you.
Thank you very much. I'll continue with you, Ms. Anastasaki.
Yes, thank you. Regarding the first question, I think that on the basis of translating knowledge into public health actions is the actual existence of modern and contemporary focused public healthcare systems. So if we have outdated systems, then of course we will not be able to use the data we collect in order to make policy. Another issue that as a researcher I have identified a challenge towards translating knowledge into action is the lack of connection, the lack of links between disciplines, between professionals, between systems. And the third challenge, that these challenges, of course, are always there, but have been increased during the COVID crisis. Another action is that in order to be able to make policy, we also need to disseminate our results as researchers. And this is an area where we are usually very underfunded for this. And of course, we always have limited time for this. So how can we use our findings, our tools, the capacities we build, if we're not able to disseminate them, if we're not able to sustain them? So, and this could be addressed by policymakers in the sense that we do create the knowledge, so we need to be contacted in order to disseminate the knowledge. Regarding the next question, it's very evident during this crisis that technology is crucial for promoting health and for designing and for implementing public health interventions. Not only due to social distancing, but that creates this need to be able to communicate remotely. But also due to, excuse me for my hesitancy here, but also due to the fact that I lost my, sorry, because we have some noise here and I lost my words. What I was saying was that we need, of course, technology during this crisis, not only because of distance, but also because we need to share data with and make comparisons with other settings, with other societies. This is the only way to promote research. And currently, we're also living in the area of big data. We need to see how we can use this data to advance medicine and public health. So technology, medical records, systems, registries, and such systems are very, and applications for enhancing communication. These are very important steps that should be taken not only during this crisis, but further beyond as well. Thank you very much.
Thank you very much. And Professor Karadimas?
Thank you, Professor Ioannis. Well, I think that the first step to implement health policy and to make some actions like that is that to have data. It's to have research on human behavior. And to be honest with you, in Greece, we don't have that. Just to give you an example, in the Netherlands, there's a friend of mine, close friend of mine, who is the head of a subcommittee in the Ministry of Health, who is conducting behavioral research since March 2020. And every 15 days, they get data, hard data, not just on perceived behavior, but also on actual behavior. And they're going to use them, not just for this pandemic, but for the future pandemics. And the cost for that is less than 10 million euros. In the Greek states, the Greek state spends hundreds of millions of euros on several occasions, COVID-wise, and they're doing a fine job with that, but they have not spent not a single euro for behavioral research in pandemic. And I don't mean research that's been conducted by universities or individual, let's say, researchers, but a more systemic work that can go in deep, that can give us the resources and the instruments to implement that kind of research. If we don't have that knowledge, we can't just adapt knowledge that is generated in other nations or other cultures, because there's the danger that this knowledge does not apply to Greece. And as far as my belief about future technology is concerned, I'm very pro let's say, science and scientific development and things like that. I strongly believe that big data and machine learning and deep learning will open the gates for findings that we didn't dreamt of just a few years ago. And on that, I would like to ask for your forgiveness, because I've promised to be somewhere else at 6:30 and I have to leave in about 5 minutes. I didn't anticipate that it will take us so long for this interesting symposium, and I apologize for that. Thank you.
No problem. Thank you.
Thank you very much. And Professor Kafetsios?
I will really echo what my dear colleague, Professor Karadimas, just said about data, and I just add the cultural element to that. As I mentioned in my talk, there are cultures that err towards behavior and cultures that err towards representations. And unfortunately, our culture is one that errs towards representations than behavior. As an example of that, we don't have a systemic way of analyzing social trends or behaviors, full stop. Any other country I know in the European Union do have a large data set following up on that every 5 years or so. So one thing is this, and also politicians, of course, they will follow the norms. The other thing is a credibility. And we are in a crossroad, I think, in terms of credibility, because on the one hand, we are seeing lots of publications, we are seeing the open access movement in science, etc. But on the other hand, it's difficult to arrive at a consensus on what's good data and what's good way forward. And there is a problem with us, interdisciplinary communication, but also conflicts within disciplines to arrive at a consensus within the academia, and then to communicate outside. And of course, we create ambivalent emotions from politicians and people around it. So these are the two main things that I identify in this time in history. And of course, normative, and Professor Chinorema, I think this is the normative element that is related to this, referred to. Thank you.
Thank you very much, Professor. Yes, please.
I didn't really answer the second question. I didn't touch it on
please,
it.
Please.
May I, for a moment,
yes, please.
spare your time regarding the second very important question too, the use of emerging new technologies. I think they're absolutely important for the issue we're talking. And the way they've been used in research, but also delivering public health services. But a note of caution here, again, from the evaluative point of view, there's so many ethical issues that have been raised and challenges here regarding not merely privacy issues, which the GDPR has been trying to address, but also issues of justice and equity. And we have to be very careful there, starting from algorithmic biases from the start. Therefore, a lesson to be learned, a normative lesson here, I think, is that when we conceive and design these new and emerging technologies, we should have built into them ethical considerations, rules, and constraints, not just added on at the end of the day after we have invented them and then say, now let's see how we deal them with ethically. Not at all. I need to stress this from the very beginning, built into them from the very conception of the designers. There should be ethical constraints, barriers, and considerations of justice, privacy, human rights, and so on and so forth. Thank you.
Oh, thank you very much, Professor Chinorema. And Dr. Petelos, with our warmly thanks for introducing this important initiative. And please, you're having the chance in giving your response. And then Professor Kousis will just kindly invite it in making a synthesis and conclusive remarks and closing the session.
Thank you. And out of due consideration, is a very kind interpreter. So I will start in reverse order. It's interesting what Professor Chinorema just said. I will momentarily share screen because we've just completed in Maastricht a survey of all the papers that are referencing artificial intelligence and ethics. And we actually identified 2,166 publications. And when we went to see who actually was dealing with concepts of autonomy, explicability, patient privacy, fairness, and prevention of harm, if you look at the number, it's abysmally low. And if I may say, I mean, this is going to the AI and Ethics, which is a new journal, in case one of you is interested in joining the editorial board. And indeed, the concept of by design, which Professor Chinorema discussed, is critical because when we interact, being in different groups, I interact with a lot of computer scientists, data scientists, and they are also asking for, training, formal training in ethics and understanding what the user wants, the patient wants, and so on. So my first point is that I think people completely miss how important ethics are. The second point has to do with a very misaligned word, even more misaligned than innovation, which is policy. Policy is not an idea. Policy is enacted in law. So you need to look at law. And if it's not in the law, hey, it hasn't happened. So what I mean to say by this is I heard the argument about data. I strongly believe in data. I'm involved in infrastructures, but do we really need more data to know what smoking kills? And do we need more data to know what sugar kills? I don't think so. So Marilena said we should reach out, the policymakers have to come to us. It's not going to happen. We have to go to them. So we are lacking as scientists, the part of the training where we understand the basic legislative elements, basic ethical elements, and basic training in communication with policymakers, because it's a different language. And it goes without saying, being in the Netherlands, Professor Koyadimas is still here. I'm very happy because the people leading the foresight studies is Henk Hildering is a friend. And we were already looking at collateral damage, and it was the first, we are training now people in foresight studies and capacity building, but it's very early days. And indeed, if you look at the money spent, you also need investment. So scientists need to advocate and more aggressively, including European associations, and I speak for you and for us too. And they need to cross-talk interdisciplinarily. I think public health, we haven't talked that much with psychology and so on. But to close on a more positive note, WHO Europe has a new unit, which is behavioral and insights. And I think that is very important. And Perhaps also we need to look at how policy is made, because if you look back at what happened this year, there was evidence for some things, waning immunity and so on, passports for immunity are happening independently of what we say be careful of. So policy sometimes in this day and age, exactly because of exponential technologies, is not shaped in a research paper. It's shaped on Twitter and on Facebook, and we need to be more agile in social media. I mean, I've seen not only in Greece, but in Greece too, I've seen legislative proposals being taken down from opengov.gr because there were a couple of very intense posts in the media and with journalists. And I've seen very good legislative pieces being completely ignored because nobody was supporting them, because there were no advocates. So I think we also need to go a little bit out of our comfort zone and train in new things and discuss more. Thank you.
Professor Kousis, closing remarks for you.
Maybe we should just give an opportunity if there is anyone in the audience that would be interested in asking a question before we close, because there are some colleagues, some graduate students with us. So.
Excuse me?
Yes.
May I say something here?
Sure.
I want to respond to Dr. Petelos, of course, about my saying. I didn't exactly say that policymakers have to come to us. I just said researchers are there, policymakers and policies can address us, but as all researchers can confirm, I guess, and because exactly this is not going to happen, policymakers indeed are not going to come to us, but exactly because of that, as researchers, we need possibly to be more aggressive in requesting the time and funds to be able to share our results, to disseminate our actions. This is exactly what I said.
I would agree, Marlena. It's perfectly
yes.
fine. For funding, of course, you need more policies. So we are going looking back. But
yeah.
Okay, thank you. For this, I see no hands in the audience, so I will follow Professor Leonis and just want to say how much I think all of us have enjoyed this. It was a very rich interdisciplinary dialogue, and it makes us realize what a big gap there is to fill, not only in the scientific fields that we've heard of today, but also in other ones, such as economics, for example, all of which are extremely needed to deal with the challenges brought by the pandemic, but also by the new technological advancements. So I hope that for everyone, this is the beginning of what could possibly lead to different collaborations, interdisciplinary collaborations. And I think that the only way to proceed is, as all the speakers have pointed out, to bring together all the different dimensions towards the improvement of public health policy for all groups that are absolutely not only vulnerable, but less privileged. So thank you very much to everyone.
Thank you.
Professor Leonis, would you like to?
No, that's only very warm thanks to all participants. And I think that's a good start. Now we're hoping and continue our collaboration through the research collaborative project, but also just having the same opportunities for next meetings. Thank you very much. Thank you.
Thank you.
Thank you.
Thank you for
Bye-bye.
Thank you.
Thank you.
Bye.
Bye.
Goodbye. Thank you.
Bye.